New timeout lengths. You can now put people in timeout for different lengths, ranging from 10 seconds to 24 hours. All right. I just got a message from YouTube. I can put people in timeout. That sounds pretty cool. All right. So, my first attempt here at a YouTube live. Actually, maybe I did that when I was back during COVID and I was doing the COVID test on myself. But, anyways, since then, I've gotten into residency. I am, I guess, going into my 5th month of residency. I'm specifically in family medicine. I'm in Syracuse, New York. Hence, you can see, the nice bubble jacket. You can see some of the rain. It's eventually going to turn to snow in a few months. And it's going to be nice and cold. And I'm coming to you from my car because of the limited time that I have during residency. But I figured what I'm trying to do is, get some recordings up here, maybe write a book about it. I've been writing, some stories here and there. Maybe they'll, help inspire people a little bit to know about family medicine, because I feel family medicine, is taken as one of those things where people are like, oh, you're only doing family medicine. That's all you're going to do. You're not doing like internal medicine. You're not doing surgery. You're not doing any of that stuff. All these things turn out to be what you make them out to be. So I started off my first month with something we call a boot camp. Each rotation's not exactly a month. It's 4 weeks. And where they give you a sample 1 week at a time of everything. And then after that, I went to the emergency department. I did my 4 weeks there, followed by 4 weeks in internal medicine. By far, internal medicine is definitely one of the most, demanding in terms of work and time and all of that. That's really tough. Especially if you do ICU. Imagine I haven't done that yet, but I've had my rotations here and there. But that's a lot of detail, a lot of writing, lots of paying attention to everything. Things are critical. Surgery, too, is definitely very critical. I think it speaks for itself. But as a family medicine resident doing surgery in my specific rotation, I'm here to give you that point of view. So basically, to wrap it up, and by the way, if it's your first time here, welcome. My channel handle goes by Prof because I was a professor before for about 13 years plus. I have 2 masters. I also have an MD. And I've decided to pursue family medicine and, still continue teaching and doing these videos. So if it's your first time here, you know what to do, right? Subscribe, like, comment, share, all that stuff. All right, but this is a wrap up because I just finished 4 weeks of surgery. And I'm just going to tell you basically like what happens during my rotation. I'm sure everywhere it's different. But during my 4 weeks, we came in for about 6 days out of the 7 days a week. And of those 6 days, our schedule is pretty much 6 a.m. to 6 p.m. So that's, 12 hours. That's literally pretty much your whole day, right? Considering when you wake up, you get ready, you head into work, and then you come back, you unwind. You're pretty much just going to bed and getting up to go do it again. So that's in terms of the hours and scheduling, what that's looking like. And then, what's happening during that. So I'll give you a typical idea, what happens as a family medicine resident in my program on a surgery rotation. And I'm pretty much sure it's similar to the majority of places. So one of the things you got to think about when you come in as a family medicine resident into surgery, one of the first things they're probably going to think about is this person doesn't want surgery, right? They didn't choose surgery. But as a family medicine resident, you can do procedures. You can do lots of different procedures. And one of those procedures, I'm interested about, they're called minor procedures. Maybe even dermatologists do them and all that. But you can remove a cyst, a sebaceous cyst. I'll leave you guys to write in the comments what are some of these things. What's a sebaceous cyst? Where does that come from? How does it happen? I'll let you ask that in the comments and I'll read it and then I'll reply to you guys about it, so I'll make it educational. What else? You're going to remove lipomas. Anybody want to comment on what's a lipoma? Right, those are going to be on the skin as well too, superficial. You can feel them. You tell me, is it going to be hard? Is it going to be something soft? What do you think a lipoma is going to be? Can it vary? Those are things we have to think about. And then also, you got skin tags as well too. So there's lots of different techniques when you're, making your cuts, right? You can make this nice linear cut. You can make something called an ellipticoid or elliptoid cut, which is very nice, and it gives you something to hold on to, and you're removing whatever that is. That's underneath the skin there. And you also have to know, as a family medicine resident, what can you cut out? What should you leave for a surgeon to cut out? Right? And then you got to suture it up, right? Are you just going to do the top? But if you do the top, what about the underlying, the dermis underneath there? Are you going to bring that close together? Are you going to approximate the edges? How many layers of suturing are you going to do? Are you going to hide the sutures? Are you going to leave the marks on the outside? So You could be a family medicine resident who just, does the clinic visits, which is very important. There's lots of primary care that we need. Or if you're interested in procedures, which I am, you can do that on top of it as well too, right? I'm also interested in emergency medicine. I was thinking about, doing a little bit more on that. But so these are things I started looking into on my rotation. So how does a day look like when we come in? You come in the morning, you get the sign off or the sign out. I always forget which one it is. I think it's sign out from what happened overnight. They say, okay, somebody came in the emergency room. This is what happened. Or the patients that, we already did surgery on, somebody had pain, somebody had nausea, somebody was vomiting, whatever the case was, this is what happened overnight, so that you know what's going on. So when you come in and you take over from that point, right? Then you go around on the patients. You go on the different floors, see how they're doing, go see the ones in the ICU, go see the ones that definitely need a lot of attention, see, do I need any orders, do I need anything changed? Those are things you have to pay attention to. And the other thing is you'll have patients which you are not the primary care team. What does that mean? That means, for example, medicine. Internal medicine is taking care of those patients. So if they're taking care of those patients, they're making the majority of the decisions. You just got consulted for something. Maybe you did a surgical procedure on and you still need to follow up to make sure that's taken care of. If you're done with it, you sign off and you say, okay, we're done following. Unless something comes up, let us know. Otherwise, we're going to move on. Right? If you're the primary care, you have to manage them until pretty much it's time for them to most likely go home to be discharged. So those are the things you have to take look for in the morning. Then you have to go back and write your notes. Sometimes, you have the time, just go back and write the notes. Sometimes now you're done rounding, but now you got pages. You got to go to the emergency department, something's going on. There's a new patient that comes up, medicine calls you, so you got to, talk to them, get report, what's going on. Then you got to go see them. So days like that, the pager's going off, beep, 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 beep. You don't have time to do all of that. And of course, the surgeons, the surgery residents, they're busy going into the OR at this time. Sometimes they need consent forms signed, obviously, because, anytime you go in for a procedure, you need a consent form. But sometimes you need to do them that day. They haven't been done before for whatever reason. So you need to go down, to the, the waiting room, wherever the procedure room is that they're about to go in. You can call it the same day surgery room, depending on, where you're at. And you got to go, hey, what's going on? Anything changed? Do a quick history physical, update that stuff, go over the consent form with them, get them to sign that so they go into the procedure. So that the morning time, is very busy. Lots of things are going on. And then, again, you're taking the pages, you're writing your note throughout the day. By the time the surgeons are done, the surgery residents are done, everybody gets together, they wrap up, say, hey, what's going on? And in my case, we were on 3 different services. I was on general surgery, thoracic surgery, and vascular surgery. And depending on how proactive you are, and this applies to anywhere in residency, is what you get to see. So if you don't say anything, nobody's really going to bother you, right? But I wanted to see lots of stuff. I want to, get good at my ultrasound technique. So when they do the vascular stuff, I go down, you put on the lead suit, you go stand over there, you take a look, you ask questions, you see the techniques. Lots of interesting procedures. So you get to see a lot of, I can never pronounce these words, but enarterectomies, they're going out and they're cleaning out the arteries because, they need to restore blood flow. Here's a question for you. What is it called when, let's say, somebody's walking and their leg hurts because they're not getting enough blood flow down to that area because it's being blocked? What is that called? You'd say that person has what? It starts with a C as a hint. All right, so, you're trying to do those things. Sometimes they put a stent in there. So you get to learn, the ultrasound. And you get to see a lot of cool stuff in there. So I think that's very helpful. And, that makes you a lot more advanced the more you get to see. So people think, I'm in family medicine, I don't need surgery, but wrong. You get to learn your suturing. Okay, I see an answer down there. Deshauna, nice to meet you. Yes, correct. It is claudication. Very good, right? So you make your experience what you want it to be. I don't want someone to come into my clinic as a family medicine doctor, have a skin tag, and then I say, hey, I know you took your time off from your schedule to, come get this removed, but you know what? When I was in residency, I didn't care about learning how to do that, so I'm going to send you to another doctor. Would you rather just have a doctor that can take care of that stuff all at once, all in one time? Of course. So, you got to, put yourself out there. You got to learn, get used to that stuff, study it, because then you can do a lot more things. You'll literally go almost anywhere. You can go into the operating room. You can go to the emergency room, right? Let's say you have a patient that's there. You can go there too. So it really brings family medicine into really what it was as an overall encompassing practice that gets to see everything. You can go if, your patient's going to give birth. You can do the C-section. You can give the, do the birth there. Obviously, if things are more complicated, you need to have OB there for sure. But, those are things that you can add into your practice depending what you want to do. So going back to the daily flow now, we've already, the surgeons are doing their surgeries, they finish, we get together, we go around, see what's going on with the thoracic cases, the vascular cases, the general surgery cases, responding to pagers, right? You go through the end of the day, hopefully nothing else happens, but honestly, what happens in internal medicine, usually around 4 p.m., they're starting to get ready to hopefully go home. So they're, putting in their final consults, their final orders, so you get to get a bunch of those calls as well too. So those are things you want to think about, and your physical exam, is very important. It's not an overall big, physical exam that you would do, on a history and physical, let's say on somebody you just met first time as a family medicine resident, but it's more like focused. So if somebody comes in, they've been nauseous, they're having abdominal pain, let's say internal medicine's worried that, they have pancreatitis, what are you going to look for? Think about that. All right, they're coming in, let's say they're in their mid-50s, they're saying, hey, the CT scan we did shows possible pancreatitis. Can you go examine them? What are you going to look for in your examination to decide, is this a surgical candidate, right? Are you just going to be like, oh, they called me, so we have to do surgery? Of course not. When somebody has a problem in their abdomen in general, what's something important to decide, am I going to open them up, right? There's a lot of answers to this, but like on your physical abdominal exam, very basic. What are some signs that you look for? I won't give you the answer right here. I want to see what people say as they go through these videos and they look at it. But what do you want to look for that would say in your physical exam while you're examining them, whether it be the stethoscope, with your hands, whatever it is, what are you going to be looking for? Like, oh, this is concerning. We might need to open them up. Like, this is emergent, right? What about a hernia case? What are you going to look for if somebody has a hernia? What are things? Does anyone come to the hernia? You're going to go operate on them? Of course not. What are you going to look for in your exam, their history and the physical, that would make you concerned? Think about that stuff, write for them in the comments, and I'll respond to you about that. All right, so that's pretty much what goes on, at least in my surgery rotation. And it was a great experience, and I took a lot from it, and definitely want to keep working on my suturing as well too. And I was trying to see if there was anything else that I wanted to tell you guys about surgery. I honestly can't think about it. If you have questions, you can let me know. I'm trying to keep these kind of short, these wrap-ups. If you want to follow me on Instagram, it's the same as my YouTube. It's Prof Roofs, P-R-O-F, like professor, and then like the roof, R-O-O-F-S. I'm always putting up stories and questions on there. I believe the same would be for Facebook as well too. They're connected. All right, so, and I think, what's the other one? TikTok? Yeah, I've been told, I had people ask me to start putting stuff there too. So a lot of things, trying to work on it, trying to make some educational things kind of short, but that's it. All right, so let me know if you found this helpful. Let me know if you have any questions. My next rotation is newborn, starts on Monday. That's neonatal, first few days of life. So I'm interested to see, how that experience is going to go. Some procedures there will be circumcisions, so I'm going to, learn that as well too. There's different types that you can do. So yeah. All right, let's see how to end this link. I see it works, so that's awesome. But take care, guys, until I see you next time.